Oh, kia ora tātou, and thank you so much, Christine, Courtney and Sue, for the invitation to be with you all this afternoon. Just want to acknowledge the really amazing energy in the room on a day when the Olympics are going. So I work as an acute general paediatrician and paediatric infectious diseases specialist across Kids First and Starship Hospital. So I feel very grateful in my role to be able to help manage children with infection sort of from the ED front door right through to the complex tertiary infections. What I'm going to do in the next 15 to 20 minutes is take you through, to begin with, some of the bigger picture issues around infection in childhood and some of the complexities around prescribing in young children. Share some resources that I find useful in my toolbox for targeting antimicrobial prescribing in children, and then show you some case scenarios and examples of conditions, particularly where there's scope for antimicrobial stewardship to improve the appropriate use of antibiotics in children. And I'm really happy to take questions at the end as well. And so infections are, of course, the leading cause of hospitalisation in early and middle childhood, and a particularly prevalent issue in Aotearoa, New Zealand, where we know we have inequitable access to determinants of health and conditions such as household crowding, damp, cold housing that really mean that we have some of the highest rates, particularly of invasive bacterial and viral infections recorded of any, well-resourced nation in the world. And for such a common problem, it's actually really complicated a lot of the time. It's not always easy in clinical practice to differentiate viral from bacterial infections. And if you do have what you think is a bacterial infection, actually trying to work out which of those infections may be self-limited and not need anti-infective treatment, such as perhaps minor pustules or skin sores, versus those that do require systemic antimicrobials. And of course, infection has massive impacts on our patients and their whānau's lives. On a global scale, antibiotic overuse and misuse is driving a global crisis in antimicrobial resistance. And all of these infections have a massive cost to our health system. In children, we know that there are really high rates of antimicrobial prescribing in New Zealand, as well as high rates of infection. And so some of you may be familiar with this publication from the Growing Up in New Zealand study, where they looked at the amount of community prescribing in young children. And so a median of 8 courses of antibiotics for each Kiwi child, in the upper North Island of New Zealand by the age of 5 years. So that's a very high rate of prescribing indeed. Prescribing in young children is complex, and there are numerous considerations which are quite different to the adult population. We have weight and age-dependent dosing, numerous considerations around oral antimicrobials, such as whether the child can manage capsules or needs a suspension. Is the particular antibiotic even available in a suspension formulation, or do tablets need to be crushed? What's the palatability of that suspension like? In particular, examples like flucloxacillin, where it's highly unpalatable. Is this a child who's actually going to be able to swallow medicines, or they spit or refuse? Do the family have a fridge at home? Is this bottle of medicine going to expire after several days? And really importantly, what's the situation like in the whānau around supporting adherence and completing a course for the recommended duration? We also know that reports of adverse reaction and perhaps allergy to antibiotic is really common in young children. Some of that may actually be driven by, intercurrent viral illness, but often parents are very fearful that their child may have had a prior adverse reaction, particularly to beta-lactam class antibiotics, which are our most commonly used antibiotic category. And of course, the global AMR crisis. We hear and see a lot of this in the media on a global stage, but also this is a really important local issue. Our Ministry of Health several years ago put out the New Zealand Antimicrobial Resistance Action Plan, and currently there is some really important work happening at the Office of the Prime Minister's Chief Science Advisor, looking at infectious disease burden and AMR issues. And I'm just so delighted that actually a GP, Associate Professor Materi Harwood, is the chair of the expert panel looking at these issues. And I think no one is really better placed than a GP working in South Auckland to have that global view of AMR issues across the lifespan. AMR, as well as being a New Zealand Aotearoa problem, is a problem in our paediatric population. And I've just listed there some of the examples of areas where we see antimicrobial resistance playing out in day-to-day general and ID paediatric practice. So nowadays it's not uncommon for me to be treating children at Starship with bacterial meningitis caused by penicillin or sometimes even ceftriaxone, non-susceptible strep pneumoniae. We see probably more in primary care in adults than children, patients with community onset urinary tract infections caused by ESBL pathogens. And occasionally these children come to our attention as well. And for these kids, there really is no suitable oral antibiotic option. Mrsa infections, particularly prevalent in our bone and joint infection caseload at Starship and Kids First, Mrsa sepsis and complicated pneumonia, and now also invasive meningococcal disease, where meningococcal isolates are increasingly resistant to penicillin to the point where ceftriaxone is now the first line therapy in local and international antimicrobial guidance. Help is at hand. So this is the first of the resources I wanted to highlight to you all today. I don't know, can you put your hands up if anyone's seen or uses Script already? Gosh, that's amazing. And for those of you that aren't perhaps so familiar with Script, Script is a smartphone app to improve prescribing in adults and children. The adult version came first, and Steve Ritchie and colleagues at ADHB in the ID department set it up. We were very fortunate several years ago to have our amazing paediatric ID fellow Sarah Primhack, who then adapted Script to a paediatric specific algorithm. And so it is really easy and straightforward to use. This is just an example of the front page of the Script app, and you click when you're in the app onto either adults over 15 or kids, and then there are syndrome or organ system specific guidance around antibiotic prescribing. It also includes guidance about when antibiotics don't need to be used and what to do if the patient has had a previous adverse reaction of the types listed there. So I can't rate this highly enough, and be really great to see more of you using Script out there. You're probably also all familiar with laboratory antimicrobial susceptibility reports. I find these really useful when thinking about best guess therapy for infections in the ED and also at Starship Hospital. And in particular, I'm thinking about the gram-negative urinary tract pathogens and what is appropriate therapy according to particular bugs that might be growing. And so I had a look last night, and I think the most up-to-date one from lab tests is actually from 2019. So we might ask Gary McAuliffe if an update is coming sometime soon. Also thinking more broadly about resources and tools, thinking about the approach to managing children with infection more broadly. A couple of really useful resources can be found on the Don't Forget the Bubbles website, and this is an open access online paediatric learning community designed for learners of all shapes, sizes, ages and stages, from undergraduate medical and nursing students, primary care and hospital paediatrics. And again, completely free to access, and you can hop on and access these interactive learning modules. They do have a bit of a UK flavour around some of the antimicrobial aspects. And within the Don't Forget the Bubbles site, there is also a fantastic, just recently uploaded paediatric dermatology atlas called Skin Deep. So much of dermatology is actually infection, and the unique point about Skin Deep is that it includes lots and lots of photos from children of varying ethnicities and skin tones, and clinical practice that I think is a really important thing, and most of our other dermatology learning resources only include children with pale skin tones, so this is a great resource. So thinking now about a case example, so thinking about AMR in daily paediatric practice. This was a little girl who I heard about at Kids First a couple of weeks ago. So a 5-year-old who had presented to her GP with fever and rigors, and a clean catch urine obtained in primary care was suggestive of UTI with leukocytes. And then this was the susceptibility profile produced by the laboratory. And so you can see, hopefully at the back, the writing might be a bit small, predominant growth of Enterobacter cloacae complex. And we've only got 2 S's, amikacin and meropenem. So really tricky situation, what to do. We ended up bringing this child in for actually intramuscular amikacin injections for 3 days, and so we probably hear about 1 or 2 kids a month like this nowadays coming through acute general paediatrics. Just want to acknowledge and refer you all to the community health pathways, where for the majority of UTIs which aren't ESBLs, there's some excellent prescribing guidance just around the approach we have to short course treatment, which is based on current susceptibility patterns in the Auckland region. So cefalexin as our first choice, nitrofurantoin second choice, with the proviso that we can't easily get suspension and tablets need to be crushed, and third choice amoxiclav. Another condition where there's scope for antimicrobial stewardship and judicious use of antibiotics is acute otitis media. Just really to say that often actually this is driven by viral pathogens rather than bacterial. And if you look at the natural history, as I'm sure you'll all be aware, actually the majority of these children will resolve by about 3 to 4 days of their illness process in terms of acute symptoms. And so really the move is towards getting away from prescribing antibiotics for AOM at the first visit. Certainly if there are very young infants or nasty bilateral disease or acute perforation, or there is a systemically unwell child, those are the sort of subgroup in which we would consider anti-infective treatment. And really important that the communication around the natural course of the illness and the safety netting is clearly signposted to parents when you're not prescribing an anti-infective. What do we use? Amoxicillin at standard dose if we are treating initially. However, acknowledging that there are increasing rates of resistant pneumococci, high dose amoxicillin is recommended if the child has had prior episodes of AOM or recurrent prescribing, and at times for nasty cases we would add the clavulanic acid. Sore throat is another complex area, and one close to my heart as a rheumatic fever clinician. Hopefully everyone's familiar with the Heart Foundation rheumatic fever guidance documents, which in summary would recommend swabbing and presumptive treatment for anyone in a high-risk demographic group. So that's our Māori and Pacific peoples between 3 and 35. In terms of important practice points to emphasise, really moving away from swabbing children in a low-risk demographic group unless you think that they're acutely unwell with suppurative complications. And just a clinical example there of a situation recently, I was called by the ED physician at Starship after a Pākehā girl had presented to CED for an intramuscular ceftriaxone injection for her group A strep pharyngitis because she had a possible history of amoxicillin allergy, but possibly shouldn't have been swabbed in the first place. And this whole situation had led to, incredible anxiety and distress for her whānau. Other points around strep throat, the clinical prediction rules that are used in some settings overseas, such as the Kaiser and Centaur criteria, have been shown not to be reliable in our local setting. Also for children after their first episode of group A strep pharyngitis, we do not recommend a routine end of treatment swab. It is an area that can be very complicated, however, if children are presenting with recurrent episodes of group A strep pharyngitis. Hopefully all of you are aware of the 2019 update to the National Heart Foundation guidelines, which includes this algorithm here, which takes you through a pathway of what to do if there are 3 or more symptomatic episodes in a 3-month period. So just sharing a case for you now, and Matt, it was interesting to hear your topic before because this has some interesting intersections. So this is a child I recently saw in Rheumatic Fever clinic at Kids First, a 9-year-old Samoan boy who had had a previous diagnosis of rheumatic fever. He had extreme needle distress and so was on oral antibiotic prophylaxis rather than the intramuscular benzathine program with variable adherence, and a community worker brought him into the clinic with a sore knee and limp. And so at that point, some of the things going through my mind were, was this boy actually having a recurrent episode of rheumatic fever, particularly given his past history? Could this be a bone and joint infection or a structural musculoskeletal problem? And just to reiterate the fantastic health pathways, thinking about rheumatic fever diagnosis, there's a really good health pathway there. And so what did this boy have? SUFI. So really rheumatic fever population, actually they're at high risk of SUFI, they're also at high risk of bone and joint infection as well. And so really we need to be thinking of all three. Rheumatic fever is a tricky diagnosis, and we have our Heart Foundation diagnostic guidelines, which are fantastic, but our current version is 2014, and I'm very mindful that they're not necessarily available in a user-friendly platform for primary care and ED clinicians. We are working to update the format of the guidelines, but I guess in terms of practice points for primary care and ED-focused clinicians, just to be mindful that rheumatic fever diagnosis can be really difficult. It's certainly almost never clear-cut at the front door whether a patient has rheumatic fever or not. Think of those differentials, and really the bottom line is if you have a child in front of you who is Māori or Pacific and not weight bearing, then they really need to be seen acutely. Another really important point that many of you will already be aware of is that non-steroidal anti-inflammatories can really markedly impact the natural history and evolution of the joint features in rheumatic fever. And so it can make the assessment of the arthritis really challenging at the hospital level. And so if there's someone with suspected rheumatic fever, just avoid non-steroidals until they're seen in hospital. Benzathine penicillin secondary prophylaxis is the cornerstone of our rheumatic fever secondary prevention and treatment, and we're so fortunate in the Auckland region and all of New Zealand actually to have free community nurse-led benzathine penicillin delivery. Nowadays, in combination with the benzathine, we would use some lignocaine and the buzzy device there typically to lessen the pain of the injections for the children and young adults on this program. Just about to wrap up now, but to note here that this is experience from around New Zealand looking at rheumatic fever recurrences. In our paediatric population, The recurrence rates shown in blue at the bottom are actually extremely low due to our highly supported, well-functioning nurse-led programs. But we do have issues with quite high recurrence rates in our older adolescents and young adults. And so certainly when you're seeing adolescents and young adults in your practices, please do ask them about whether they've had a past history of rheumatic fever or ever been on the penicillin program, and referring them back through to the District Health Board if they've dropped off benzothine so that they can get back on secondary prophylaxis will be such an important step towards reducing recurrence rates in this adult group. Infectious gastroenteritis, just a quick point there. Recently, you would have noticed that many of the labs are now doing multiplex PCR testing, and we get increasing PCR-based diagnosis of all sorts of infectious gastrointestinal pathogens. I think it can be difficult to interpret these because the PCR can remain positive sometimes for many weeks or even months after the infectious phase of the illness has resolved. And so really there's very few situations where systemic antibiotics are needed for children with gastro, and that tends to only be the young infants or the immune compromised or extremely unwell, in which case probably they should be assessed in hospital. Finally, immunisation. Couldn't have a talk without mentioning immunisation. It has such an important role actually in tackling global AMR issues as well as protecting our children and young people. There are obviously concerns at the moment about the impact of COVID-19 and the response to routine coverage for children. Certainly in the last few weeks we've been seeing lots of invasive pneumococcal disease through Starship and chickenpox circulating as well. So really supporting the routine immunisation program. Also a plug for influenza vaccine for eligible children, and so that's actually quite a few children, anyone under 4 who's been hospitalised with a respiratory illness or on a preventer inhaler, and children with complex medical conditions. Certainly whilst we don't have influenza circulating at the moment, there is quite a concern in the wider community that if following our current RSV mini outbreak we have influenza, that will be very serious indeed in terms of strain on the health service. Another final immunisation mention is that Bacterial, so the multi-component meningococcal B vaccine, is now funded for a selected group of high-risk children, and so those with previous meningococcal disease, close household contacts and high-risk medical children can access this free and funded from the 1st of August, so tomorrow. So I might just wrap it up there, everybody, but thank you very much for your attention.